let's get started here. So these are my disclosures. Unfortunately, I root for the Jets and the Giants, so that is a lost cause. So as we know, bladder cancer is one of the most common malignancies of the urinary system. It's the 6th most common cancer and the 10th leading cause of cancer death in the United States. It accounts for 4.5% of all new cancer cases in the United States. The case rate has declined slightly. The death rate has basically remained stable over the last several years. Let's see if I can move this forward here. Great. So we know that bladder cancer incidence increases with age. The median age of diagnosis is 65 to 74. Actually, I think in my own clinical experience that's changing. I'm seeing younger patients with really essentially sometimes no risk factors developing metastatic urothelial carcinoma, also locally advanced. But the median age of diagnosis is 73. 3/4 of patients with newly diagnosed bladder cancer are over the age of 65, which of course engenders its own issues in terms of other medical complications and problems. The incidence of mortality rates are 3 to 4 times higher in men than in women, and the lifetime risk is 2.4% for both sexes. So we know there are really 2 different forms of this disease. Muscle invasive, non-muscle invasive. The muscle invasive is the type, of course, that can be fatal, that can lead to metastases because, as you know, the muscle involves lymphatics and blood vessels. And then, of course, the non-muscle invasive disease includes TA, T1, TIS. That's about 70–80% of bladder cancer overall. 10 to 15% is muscle invasive, and another 10 to 15% is first-line metastatic. Now, the question, I can't seem to find this data, and maybe somebody can help me with this, but you know, we talk in prostate cancer about de novo versus metachronous bladder cancer. I haven't seen any stats of the number of patients who've initially been diagnosed with non-muscle invasive disease, go on to muscle invasive disease, and then are metastatic. And is there a biological difference in how these patients come out in terms of outcomes? I think that's, in terms of clinical trials, it's something we may want to start thinking about in terms of the aggressiveness of disease. Maybe somebody can answer that question. I can't seem to find that data anywhere. Bernie, maybe you've got an answer to that.
There is a little bit of data that's beginning to come out on the BCG unresponsive group of tumors, where we're beginning to see, for instance, ERCC2 mutations not at the same level, perhaps DDR mutations that may not be occurring at the same levels, to suggest some of these may be more platinum insensitive in the progressors from non-invasive to invasive changes.
Interesting. Well, that's going to be important in terms of designing trials in the future, clearly, in terms of sensitivity. So, you know, 10 years ago, we couldn't really say that we've made a lot of progress, and there's been a lot of progress within the last 10 years. In fact, often bladder cancer was the pariah amongst industry because most of the trials that we were doing in the early part of this decade were failures. We really didn't see improvements in survival. And we've now seen a plethora of approvals for bladder cancer. So in 2019, Enfortumab vedotin received accelerated approval as a third-line agent for metastatic disease, and the full approval came after the EV301 trial was published in 2003. Erdafitinib also received accelerated approval in 2019, full approval in 2024. This is, of course, for second-line metastatic disease. EV-Pembro, 2023. Estilodrin was approved in 2023 as well for BCG unresponsive or high-risk tumors. And gosh, I can't pronounce this one, Nogapendikin alpha, and forget the rest of that, for BCG unresponsive non-muscle invasive. I'm sorry? NAL3. Well, it's, anyway, it's a mouthful. But that was also approved in 2024. And then nivolumab cisplatin gemcitabine was also approved in 2024 for first-line metastatic urothelial carcinoma. So again, think of the progress we've made. And then, of course, this is going to engender its own series of problems. How are then we going to think about first-line, second-line neoadjuvant therapy, and how can we position clinical trials? So this is a long list, but these are clinical trials, current clinical trials for non-muscle invasive bladder cancer, BCG naive. As we see, there are multiple permutations of combinations of checkpoints plus BCG, combinations with other chemotherapy agents such as epirubicin, rapamycin. All of these are now being evaluated. And the question, of course, is how are we going to then sort this out, given the limited number of patients that may be eligible for clinical trials? For BCG recurrent, we have pembrolizumab, we have intravesical BCG, both in induction and maintenance. Nivolumab has been evaluated, pendigatinib has been evaluated, metformin has been evaluated. All of these have gone to clinical trials as well. And then BCG unresponsive, a variety of different combinations, IL-15 combinations. Interestingly, there's a combination of a GLP-1 inhibitor plus gemcitabine. I guess this is novel, but certainly this is something that is different from a mechanistic standpoint. But again, these all involve checkpoints, vaccines, also different types of agents in combination with basically a checkpoint backbone. So intravesical vinculum, unfortunately, was not approved by the FDA, but erdafitinib was evaluated on an oral basis and was found to have a significant amount of toxicity. As we know, the drug can have toxicity when it's given to patients systemically for metastatic disease. There are trials also looking at intravesical BC819, again, an IL-15 derivative in non-muscle invasive disease. I think the most interesting trial is the BRIDGE trial, because that's going to answer the question of intravesical BCG versus gemdosi. And of course, it's going to basically, from an economic standpoint, give us some information in terms of whether this combination, which is relatively inexpensive, can be compared to BCG. And of course, with BCG shortages, these are issues. We also know that there are trials that are looking at pre-existing immunity in terms of BCG, and it seems that those patients who have a positive PPD, of course, as one would think, these may activate the antigens better and then lead to an overall better outcome. PPD positive versus negative turned out to have a better overall outcome. So SWOG 1602, which was PRIME, has looked at this particular question of I'm sorry, that's a different trial. 1602 is another trial that's looked at different types of BCG to expand the different uses of BCG in patients who have non-muscle invasive bladder cancer. I think one of the more exciting areas in terms of clinical trials is using this particular pretzel, which can release drug on a more sustained basis within the bladder. It's inserted basically on a weekly basis. It's the size of about a euro. Of course, if the euro is going down in price, then we're in trouble. But TAR-200 has been evaluated in patients giving different agents such as erdafitinib. It's also been evaluated with BCG, with gemcitabine. And the big advantage to that is that there seems to be less toxicity when it's administered in this particular fashion. And there does seem to be significant efficacy. This is a TAR-210 in non-muscle invasive bladder cancer, 82% recurrence-free in FGF-altered patients. So certainly this, again, does not have the systemic toxicity that we see with BCG, with erdafitinib in metastatic patients. 87% in the first trial achieved a complete response. Hey, Bernie, would you like to make any other comments on clinical trials in non-muscle invasive bladder cancer?
So I think we have an incredible group of folks that have been intimately involved in a lot of the new agents that are happening right now. And I know throughout the day tomorrow, we're going to be able to get their opinions about where they see the field going. But I think that you've hit pretty well on a lot of the agents. We're really excited about some of the targeted agents that are coming out right now. But it's remarkable the number of different new options that are out there. The challenge is going to be to figure out sort of how to integrate them into clinical practice.
Exactly. And sequencing, I think, is going to be the key. And we're seeing that same issue in metastatic disease. So there's been a paradigm shift in the treatment of patients with metastatic bladder cancer. As we know, chemotherapeutic agents such as, or combinations such as GemCis, the MVAC regimen, improve survival, but only about 5 to 10% of patients using that as, without immune therapy, have a 5-year survival. Maintenance immune therapy has shown an improvement in overall survival by about 7 months, and this was considered to be the standard of care until Enfortumab and Pembrolizumab came along and demonstrated a median survival of about 30 months with a CR rate of about 30%. So given this, how are we going to incorporate new agents into treatment, and then how do we properly sequence them? As we know, Enfortumab is an ADC, which targets Nectin-4. Nectin-4 is expressed almost ubiquitously in urothelial carcinoma, and we know that one molecule of Enfortumab will deliver 4 molecules of MMAE, methylmonoauristatin, which causes an antitubulin effect and causes cellular death and apoptosis. And also, there does seem to be an immune effect from this particular compound as well, and that may be the reason why we see such great activity with EV-Pembro. This drug was developed through a series of clinical trials, phase 1, phase 2, phase 3. The phase 3 study in patients who've had prior chemotherapy and 1 prior checkpoint therapy showed an improvement in the overall survival, median by about 4 months, and a hazard ratio of 0.7, showing a 30% reduction in risk of death in that particular state. And then the exciting data that was presented with EV-Pembro last year, looking at EV-Pembro, slightly different schedule for Enfortumab, 1.25 milligrams per kilogram, compared to the standard gemcitabine plus cis or carboplatin, showing again an improvement in overall survival, a 53% reduction in the risk of death compared to chemotherapy, and a 55% reduction in progression or death compared to chemotherapy as well. So this really is a major advancement. This comes at a cost, and the cost is neuropathy as well as skin rash. And the neuropathy, in my experience, once it occurs, is pretty much permanent. And we have patients from the original EV-103 study who still can't sense the difference between hot and cold, or still can't feel their feet. So this is something that needs to be carefully monitored in patients who are on treatment, and is particularly relevant in somebody who may be receiving neoadjuvant therapy when these treatments are moved up earlier, and the toxicity can be more significant over time. At the same time, Checkmate 901, nivolumab plus GemCis versus GemCis in first-line urothelial carcinoma was also presented at the same meeting, and also appeared in the New England Journal of Medicine. And this gave nivolumab until progression in patients who received the combination of GemCis, the triplet therapy, versus the double therapy of GemCis. And that also showed a survival benefit, but we would have been jumping up and down about that 5 years ago, but wasn't of the same magnitude that we've seen with EV-Pembro. So this is the way we sort of look at urothelial carcinoma. I think the issue about platinum eligibility now begins to go out the window because of the fact that EV-Pembro can be administered both to cisplatin eligible and ineligible patients. And then, of course, what's going to happen in the second line? Are you going to give standard chemotherapy? Are you going to start giving other targeted agents such as erdafitinib or other investigational agents? Should we move the investigational agents up in the combination? Is it going to be too toxic to be administered? And there have been trials that have looked at giving sacituzumab in that particular situation with the EV-Pembro, or there's actually a trial called DAD, which is looking at both sacituzumab and EV without the Pembro, showing actually a high response rate of about 70%. But how do we integrate these in our patients? And also, how do we look at risk? Because actually Rob Dreiser, a number of years ago, had a randomized trial of GemCarbo versus MVAC. And we had a lot of trouble getting patients on that study. But when you looked at that trial, the data that was based upon, most of those patients who did well were those patients with nodal disease. And unfortunately, that led us down the garden path. And we have to be very, very cognizant that metastatic disease is heterogeneous. There's a difference between nodal disease and a difference between visceral disease, somewhat wiped out by EV-Pembro because you see responses in visceral patients. This was an unfortunate study, and again, this is clinical trial development, and the perils of accelerated approval. So sacituzumab govitecan, a drug which can be somewhat difficult to administer, and I still cannot figure out why the breast cancer people have been able to give this safely and the urothelial people have not. It may be something to do with the fact that bladder cancer does make GCSF, and you may be affecting the cells in some fashion. This drug does have significant neutropenia, and it's unpredictable. And this was approved on an accelerated basis based upon an objective response rate of 27%. The TROPiCS-4 trial was the confirmatory study, sacituzumab govitecan in third line versus standard of care chemotherapy with paclitaxel or docetaxel. And unfortunately, it did not meet its overall survival endpoint. And there were reasons for that. The reason was that there were a lot of toxic deaths on the sacituzumab govitecan arm, and this was due to neutropenia. These patients were not prophylaxed with GCSF, which was something I commonly do and a lot of other investigators do as well. So unfortunately, because of this fact, the accelerated approval was withdrawn, and the question is going to be, are you going to be able to get this drug in a late-line patient because of the withdrawal? And I think that that's going to be an important question. Hopefully the NCCN will answer that in a positive fashion. So, as I mentioned before, how do we incorporate these? Add to the backbone, improve toxicity and efficacy using alternative nectin-targeted agents, evaluate drugs in the salvage setting. I think these are the ways that we can improve the field. We know that bladder cancer is heterogeneous and there is no one agent in terms of signal transduction that stands out. FGF, 10 to 15% of patients. ERB2, maybe a little bit more, a little bit higher rate. EGFR, 6%, but this is different than lung cancer. And we looked at this question in SWOG using ERISA. And before the era of identifying EGFR mutations, they're not present in bladder cancer like they are in lung cancer. And that's why this particular class of drugs has failed in this disease. So we have targets that we can pursue, PI3 kinase, and the question is, how? Are we going to move into the age of targeted therapy? And really, the two important molecular markers that we need to look at are FGF, and all mutations from 1 to 4, and then HER2/neu, because we do have drugs that are dependent upon that. Erdafitinib, and then dasatinib vedotin, as well as TDX. This is approved for HER2 on an agnostic basis. So all tumors that express HER2/neu are potentially can receive this particular drug. PD-L1, I generally don't use it at this point. I'm not sure if anybody in the room does. I really don't think it's helpful in determining whether a patient should go on a particular drug. And then Nectin-4 really, since it's expressed at such a high rate, it's not going to tell me whether a patient should go on EV or EV Pembro. So these are markers that are useful, but are targets, but not useful in determining which drugs to use. There's some new exciting drugs right now that are now in clinical trials. Proteins actually are important to be folded, or the folding of proteins is important to its activity. And short linear peptides, if you put them into the bloodstream, are easily digested by proteases. When you start putting them into these cyclic compounds, like bicycle compounds, they can actually be resistant to degradation, and they can go to high affinity targets. So there have been these bicycle proteins that will deliver Nectin-4, will target Nectin-4, and deliver MMAE to different targets, such as F2, as well as Nectin. And this is the bicycle conjugate with MMAE, and it shows a very, very high affinity to Nectin and has a very prolonged toxicity to the tumors itself. And this is now in clinical trials. We'll be discussing that more tomorrow. Similarly, by altering the ADCs in terms of their linker technology, you can get different amounts of release of MMAE. I mean, some of the thoughts are that MMAE may actually, free MMAE may actually be responsible for neuropathy. And then, of course, the conjugate, the strength of the conjugate may actually be important as well to not releasing MMAE into the bloodstream. So another compound, CRB-701, is now in phase 1 studies, looking at whether this will have less neuropathy and potentially fewer side effects overall, and maybe better response rates. So again, we can alter the structures. So there's increased internalization with this drug. It's a different linker. Let me go back. And then the payload is also retained at a higher rate. In this way, you can dose on a Q3-week basis rather than a weekly basis. So emerging targets for clinical trials, I mentioned HER2/neu ADCs. There's dasatinib as well as trastuzumab deruxtecan, a variety of different Nectin-4 agents, other TROP2 agents that are targeting that particular area. F2 is present in bladder cancer. And then there are some ADCs that are now being developed that are really, really unique, where you're basically attaching two drugs to one particular ADC. So you can actually do combination therapy with an ADC, and I think that's a very, very exciting area moving in the future. Moving up front, we know that platinum-based chemotherapy has been the mainstay of neoadjuvant treatment, and we've seen recently the results of the Niagara trial, which are showing an improvement in overall survival for those patients who receive GemCis plus checkpoint versus GemCis alone. The issue, of course, is do these patients need to continue the checkpoint past their, if they have a complete response initially? And of course, the control arm did not have any checkpoints involved as far as adjuvant therapy is concerned. But there are two trials I think that we're really awaiting the answer to. There's the Keynote 095 EV303 study, which is taking cisplatin ineligible or cisplatin eligible patients who decline cisplatin, and basically there are three arms initially before surgery: pembro plus EV or observation, then radical cystectomy, and then adjuvant treatment afterwards. And this, of course, will answer the question whether the non-platinum doublet can be administered to patients preoperatively. And then there's the VOLGA trial, which is taking cisplatin-ineligible patients with muscle-invasive bladder cancer and randomizing them to one of three arms: durvalumab plus tremelimumab plus Enfortumab, durva, Enfortumab as a doublet therapy, and then straight to cystectomy. And this trial is close to being accrued. So I think at this point we have multiple trials that are focusing on novel immunotherapies targeting BCG, refractory recurrent urothelial cancer. There are agents targeting Nectin, HER2/neu, TROP2 that are being investigated in metastatic urothelial disease as well. And the question is, what's the best sequence? And I think that tomorrow we should focus on that and focus on how we can improve that 30% CR rate and 30-month median survival we see with EV Pembro, with, of course, less toxicity. Thank you, and let's open the room for discussion.